So we're always going to expect the best, but prepare for the worst. So gave you just fundamentals on positioning a latch, but there's always the what if, and that's what I want to talk about. So say I'm feeding my baby, I do everything right. I'm positioned perfectly. I compressed the breast like a sandwich. I tickled the baby's lips. The baby opened, I brought him on. But you know what? It hurts the entire time. This is the problem. I don't care if 100 lactation consultants come and look at your latch. If it hurts, something's wrong. So unless they have an ultrasound on the baby's cheek, actually seeing what's going on in the baby's mouth, you cannot predict if the latch is good or not. So I want you to put your tongue on your roof of your mouth. That's your hard palate. Breastfeeding is compression. So what happens is the baby's tongue goes down and they create a vacuum seal to suck the milk out. And in order to do that, the tongue is constantly moving. If there's pain that lasts past the first 30 seconds, guess what? That's what's happening to your nipple. The tongue is smashing your nipple against the hard palate. And imagine if you had a wound and every 3 hours I kept scratching that wound. What's going to happen after a couple days? It's going to be bleeding, possibly infected. So we're going to take control of the situation right from the beginning. Babies sometimes in utero suck their thumb and create high palates. They sometimes have tongue tie. We have time to figure out what's going on, but we're going to talk about quick fixes in order to make sure that you're not in pain and you don't get to that point where you have cracked, bleeding, sore nipples. So if we do everything correct and the baby gets on, there's a couple potential problems. One is lack of stimulus for the suck reflex. So all those reflexes, if you put something on the roof of the baby's mouth, and we're talking a breast, a bottle, a pinky, a pacifier, it's going to stimulate the suck reflex. They will suck on whatever you put on the roof of their mouth. For the first 3 months, the great thing is we really can't make many mistakes. They, for 12 weeks, have all these involuntary reflexes. So if you've heard about nipple confusion and a baby getting used to the bottle and a baby getting used to being held and manipulating you, all of that is not true. We know based on the evidence that babies, it's kind of like the 4th trimester, for 12 weeks are just involuntary reflexes. So if a baby feels like they don't want to breastfeed or they get on the breast and do this, it's just plain and simple, we're not stimulating the suck reflex. So how do we fix that? If you were pregnant and you noticed that your nipples retracted upon compression, or you have super flat nipples, or another thing, the size of your breast. If you go from stage 1 of lactation, where you're only making a teaspoon of milk, and then go to stage 2 of lactation and your breast is this hard, how is the baby supposed to latch? So there are tools, and my favorite is the Medela Contact Nipple Shield. They're available on Amazon and a lot of stores. The difference with the hospital is they don't give them out regularly. They don't let regular nurses give them out, only lactation consultants. So there's a lot of misconceptions about them. So 95% of my patients would fit the 20 millimeter nipple shield size. And again, this is the Medela Contact Nipple Shield. Highly recommend it. The reason it's called a contact nipple shield is it has a cutout, and that's designed to go where the baby's nose is so that the Montgomery glands are exposed and the baby can smell you. So say you're in pain, it hurts the entire time. All you have to do is use a nipple shield. You will place this over the nipple, and I can use this pillow as an example. It's a really thin piece of silicone that fits over your nipple, and it protects it. It makes it physically impossible for the baby to damage the nipple. You do the exact same thing, tickle the baby's lips, the baby opens. You just want to make sure that you don't see any of the nipple shield. The baby should be flush against the breast. To wash the nipple shield, it gives directions, but not necessarily exactly what I would recommend. So to recap, 1 drop of breast milk has 1 million living white blood cells, so we don't really worry about bacteria. It's more stickiness. If you're using it and breast milk gets on it and maybe you use some nipple cream, it will get cloudy, and if you put it on, it'll fall off. So general rule is to wash it with just a tiny drop of dish soap and water, and in between feeds, flick it dry, and you can use the same one over and over and over. So you would feed on one side, and then you can switch it and feed it on the other side. So the contact nipple shield, again, the opening goes where the baby's nose is, and if you mess up, it's not the end of the world, but that's why it's called a contact nipple shield. So you would tickle the baby's lips, and then you just want to make sure the baby is flush against the breast. They're not falling back on the nipple shield.